title of this presentation is Introduction to Intranerual Facilitation. And to provide some context, I am Mark Bussell, and the founder and clinical director of the Loma Linda University Neuropathic Therapy Center. It is unique. It is the only center of its type, and I'm an assistant professor for research with the School of Allied Health Professions. I had the privilege of graduating in 1989 with my bachelor's, came back 25 years later, and graduated again in 2013. In the meantime, I developed the intranerural facilitation system for treatment of neuropathy back in 2007, and had the chance to bring it to Loma Linda back in 2011. The Neuropathic Therapy Center is unique. It is a unique collaboration between the medical center and the School of Allied Health. We have 5 therapists with office support and admin support, and our purpose is to both research and treat neuropathic pain. Right now we only take risk insurance or private pay insurance, and we're also working on obtaining insurance coverage. And we have new CPT codes, and we're working on new CPT codes so we can get insurance coverage. There's some challenges. I'll go into the challenges of a new type of rehabilitation later on in this presentation, but anyway, including the insurance piece. We use a unique program called Intranerual Facilitation, which I will be happy to discuss here in just a second. Because this is a research facility, and for the treatment of neuropathic pain, there has been emphasis in publishing. The first study has been published in 2016 involving balance with diabetic neuropathy. It was a pilot study involving pre-post design, and it was a strong study nonetheless, indicating or showing that patients that had intranerural facilitation and had a history of diabetes had improved balance as well as improved sensory scores. We have recently completed a carpal tunnel study involving neurology, as well as a diabetic neuropathy study, which involved the School of Allied Health. We're excited about both studies. We're excited about the results of both studies, and we are looking forward to having those studies peer-reviewed. Carpal tunnel study showed strongly in favor of the patients that received intranerural facilitation improving as a result of their treatment versus the sham group, which involved more exercise. The diabetic neuropathy study is also showing some progress, or actually some results in favor of the treatment group, the intranerural facilitation group. There are ongoing studies. This is the one study that I'm going to speak to, is a study involving nursing and oncology. And I'm excited about this study as it is reviewing the possibility of preventing neuropathic inflammation to see if that's a possibility. We have 2 arms to the study. One involves exercise. The second arm involves intranerural facilitation. And we're looking at patients that have started with taxane therapy for breast cancer, and to see if we start with these interventions, if they will be less likely to have neuropathic results as a result of the neurotoxic medication that they're receiving. We're also looking at dietary influence on diabetic neuropathy with INF therapy. That's going to be coming up as well. Other studies that we're looking at as well has to do with cytokine levels. So, and that's also down the road as far as our research is concerned. So this is exciting. There's the program we have here at the Neuropathic Therapy Center involves 4 different aspects. The one that we'll be talking about today is INF, or intranerural facilitation treatment aspect, and then there's 3 other components as well, which are listed as below. The NVI stands for neurovascular index. It's a way that Loma is patenting to potentially look at neural circulation in relation to ultrasound assessment. So, and that's it'd be for a different lecture. But we're excited about that as a potential way to quantify circulation that is in the neural connective tissue. Another component of the INF program at the NTC Center is a home exercise program, and we'll review that as well with this discussion today or presentation, as well as the NVI allergy assessment. Now we look for potential for autoimmune factors that could be antagonistic to the therapy. So those factors may be, like gluten for celiac disease, something like that. Okay, so why care about a manual therapy treatment for neuropathy? There are other homeopathic interventions. There's electrical stem interventions that are non-invasive. There's TENS units. There's also there's acupuncture. So why do we care about a manual therapy treatment? And I wanted to just speak to that briefly. We feel like there's some advantages if you're able to bias or coax circulation into an anischemic nerve. To start with, this therapy treatment is based on Western medicine. It makes it easier. My intent is not to speak against other medicine types, Eastern medicine, for instance. The Western medicine is important in a sense because that's what we're trained in, so it's easier to train and teach other people how to use this therapy. We can train, for instance, occupational therapists, physical therapists, all who have interest in bringing circulation to nerves through a potential bias, and maybe others as well. And so, we're evaluating and getting ready to start a training program so that we can have people within the profession, but there's some advantages in that sense. We can also uniquely identify and target areas of greatest ischemia, and I will speak to that later on with this discussion. We can also know when to start and stop the therapy, and I'll speak to that as well. Palpation, for instance, will be able to feel when the circulation is finally all the way into the nerve, the tissue changes. There's changes in color. We get changes in muscle tone. It's not hard to see once you finally, grasp the therapy and the treatment. So, and in addition to that, as we see a patient come from session to session, we can train practitioners to look for oppositional factors, factors that could be antagonistic. And so, and that's important as well as we're looking to improve the circulation in the neurovascular tissue. So I think that these are important maybe distinctions. Anyway, intranerural facilitation as a treatment, an overview. The entire purpose of the treatment is to reestablish a vascular path to an ischemic nerve. And we look at where the nerve is, potentially the most inflamed. At that point, we presume to treat neuropathy through systemically pushing blood into the ischemic neural capillaries. To do that, I'll share a little bit of our thought as far as the model of ischemia is concerned, involving a potential organ for neurovascular circulation. The therapy does not involve, and it's curious that it does involve massage or strengthening, but it's still a manual therapy. We'll talk about that briefly as well. I think it's important to consider that, can you really do something that's impactful, that's not invasive, it's not involve medication, but still bring circulation into the nerve through a scheme, through a method. And to do that, you would need a way or something that would facilitate bringing that method, that systemic circulation into a closed container system. So intranerural facilitation involves 4 different holds to do that. The facilitation hold is a hold that starts the therapy. The secondary hold, the sub-hold, and INF sensory hold will be discussed. So if you were to, again, to think about intranerural facilitation as a way of bringing circulation into a closed system, and it'd have to be a closed system since we're not using strengthening or massage work. What we do know about the neurovascular circulation as a closed system, as a system that does not have a stop and a start to it, but it's essentially all-encompassing for all the nerves, we would again look at it as being continuous, and it's comprised of essentially two different compartments with communicating branches between the outside and the inside of the apartment, and we'll review those briefly. So it functions to remove waste from nerves, as well as supply oxygen to nerves, and it, in a sense, may be considered the wholeness organ. So with the neurovascular circulation, you're looking at a circulatory organ that can be impacted by sleep, it can be impacted through stress, it can be impacted through what the foods you eat, spirituality, and so it's kind of interesting in a sense, maybe in a lot of ways we're impacting this closed system and with our treatments, and we maybe didn't give it that much thought. Okay. So the first introduction to neurovascular circulation for myself included patients. Actually, my own mother-in-law was one who has neuropathy, and I was looking at osteopathic holds and positionings, and what I noticed is that when I would when I would change or position a specific hold, and I would put a joint into maximal loose pack position, that I would actually help. In this case, my mother-in-law, with her neuropathy, would actually start to subside in her other foot. And it was sort of curious. And I was, looking at, I have some special needs boys, I was looking at different ways to potentially intervene in a way that was didn't have any side effects. And as a father, you're looking to improve and reduce inflammation if you could, and have my manual therapy background and looking at alternative ways, I sort of stumbled on this effect. And I brought this effect into the clinic, and I had patients that were fibromyalgia patients, CRPS patients, patients that had migraines. And so I would do at the foot, I would do a plantar flexion and full supination hold. And then the patient, I wouldn't sort of cue the patient, I'd just say, tell me what you feel. And the patient would all of a sudden start to explain that they had increased paresthesias, tingling, numbness, whatever, that they were in the areas where they were previously injured or reported that they had symptoms. And it kind of made sense. These are sensitized nerves potentially within nerve trunks, or sensors within nerve trunks, so to speak. But what was interesting is when I would stop the hold, the patient would then just spontaneously say it stopped. And so that was my first introduction to the potential. And observing this, I got the feeling that indeed that maybe I was stumbling onto something that had been researched, but didn't know really that you could potentially access or influence it in a predictable fashion. So I kind of liken it to increasing oil pressure, and potentially I was bringing more blood flow in from the macro system, from the arteries and arteria and a large vessels, aorta, or accompanying large arteries down the leg, for instance, and bring them into smaller vessels within neuroconductive tissue. So the first hold for intranerural facilitation is the facilitation hold. And the facilitation hold starts with what I described earlier, bringing the joint into a maximal open chain loose pack position, sort of the facilitation effect. And the feeder vessels are important. They can be damaged through diabetes and probably with other types of neuropathy. If you section numerous feeder vessels, which essentially are connecting vessels between arteries and epineural arterioles, then after a number of sectioning, then the circulation becomes stagnant within the endoneurium and even the epineurium. So, okay, so here's an example of a schema if you would, of how I can get circulation to bias more consistently using the initial facilitation hold from arteries into neuroconnective tissue. This would be the foot. Here we have what would be considered a nerve. The yellow would be the nerve, this would be the artery, these would be the connecting vessels between, which are clustered at joints. And so at this point, if we were to pull his foot with a strap, we're pulling the nerve and an accompanying artery, and these are now straightened. So before they were curled, now they're straightened. And what we're saying is right here at the point where they're straightened, that would bias circulation into the epineurium. So here is a closer look at what we're talking about as far as that opening is concerned. This would be the ankle neutral position. This would be the presumed opening between the artery and the epineurial arteriole, and this would be the feeder vessels and nutrient vessels in slack position. And right here, we're also outlining some other layers of the neuroconnective tissue with the nerve down here in the endoneurium. Now, as we pull the foot in maximal loose pack position, what we believe is happening is we're straightening out the nutrient vessels. Circulation then can more consistently go from macro to micro circulation with emphasis with more blood flow into the epineurium. Now, just a side note, the patients felt changes with sensitized nerves. Now, there's no recurrent nervi nervorum or nerve of the nerve in the endoneurium. So what they'd be feeling would be changes with most likely with the epineurium or the endoneurium. But anyway, so that would be an example of opening up circulation and bringing it into the epineurium. Now I want to talk about pressurizing a system. What we believe is going on is it's a closed system, and that's what research has indicated, and that's that the neuroconnective tissue have closed vascular systems. So especially in the endoneurium, but also in the epineurium. So if we were to say, take a look, if you would, the facial nerve, this would be the artery here, and this is the epineurium here, and this is the epineurium. Right now, this is the nutrient vessels on slack, and this is happening at the perineal artery, the fibular nerve, so to speak. We now put it in the maximal loose pack position. This is stretched out, circulation's now going in here to the epineurium. What we believe is going on now is that now you have consistent circulation also in the epineurium of nerves distal to where this has started. And in this case, we're saying it would be occurring at the epineurial arteriole and the facial nerve. Okay, secondary holds are necessary to bring circulation into the endoneurium. So secondary holds, this would be our treatment area. Treatment area typically would be stretching of the skin, muscle, or joint. And the success of the treatment depends on if we can actually establish that vascular pathway and bring a consistent blood flow that now is patent to, say, somebody's skin who has small fiber neuropathy. Okay, so what we're saying here is that this would be, again, the epineurium going through transperineal, this would be the arteries going through feeder vessels into epineurium, going through transperineal vessels into the endoneurium right here. But what happens, how can I coax pressurized blood flow from my treatment and to get it to go into the endoneurium? Because if you have swelling from stasis inside the endoneural capillaries, different research studies by Lundberg, Myers, and others have shown that there's going to be a valve mechanism that occurs with increased pressure inside the endoneural compartment that pushes up onto the perineurium and creates a stricture of the transperineal vessels. So it's unable to reinforce the longitudinal circulation going in endocapillaries. So I pressurized here, but this is still closed. So now the secondary hold presumes to pull on the perineurium and create sort of a disengagement of the stricture there that's closing out the transperineal vessels, and now the pressurized blood flow can go into the endoneural capillaries. So now let's illustrate this. In a sense, I have sciatic nerve or sciatic nerve neuralgia with sciatic. I want to get circulation into my intraneural capillaries of the sciatic nerve. And so how do I do that? So I have my facilitation hold that pressurizes the circulation in the epineurium. So here we're saying this is pressurized flow in the epineurium. Okay, well that's great. And so, but then we're going to be stretching out the hamstring muscles. Well, what does that pull on? That pulls on the motor efferents. That also pulls on even afferents or going into muscle spindles. But it pulls on nerves that go into the sciatic nerve. And so at that point, it's going to also pull on the connective tissue and also going to pull on the perineurium, allowing the pressurized circulation to go through the transperineal vessels into the intraneural capillaries. So this is nice because now we can choose, in essence, whether it's the facial nerve, whether it's the trigeminal nerve, whether it's a sublingual nerve, whether it's maybe the median nerve, ulnar nerve, or whatever. We can target, and if we can correctly identify through palpation, through patient reports, we'd say, okay, this is where your circulation is going to go, or at least this is where our treatment, in fact, the maximal treatment impact is going to be. It's going to be on the nerve that you need it the most, as opposed to maybe putting a machine or pads on an area and hoping that it catches the circulation and gets a desired treatment impact. All right. So, subholds. Subholds are a little more difficult to explain, but necessary to accelerate circulation once we get into the intraneural compartment. So, what we're saying is this: let's say we brought through the secondary hold, the facilitation hold, we brought circulation into the intraneural compartment. That circulation came and met with upstream resistance. You get more capillary reclosure as it's trying to get through the skin, through the plexus in the skin, or maybe it's going back up through, we'll say, if it's the foot, it's going back up through the plantar nerves and the tibial nerve, and it's getting upstream capillary resistance. So how do we increase that flow rate so that it can navigate, it can push through, it can create nitric oxide release, it can create a vasodilation as it's pushing through those capillaries. So and that's a challenge. And so what we developed is we said, well, if you use bolster placements distal to where your new circulation is going, you do it in a pattern way, and we've developed a pattern to do this, that we could create almost a vacuum, and it does increase the treatment impact, and we're able to do more as far as a better clearing of the circulation of the area that we've targeted by using bolsters and essentially even subholds or extra holds away from where we're bringing circulation in. So subholds, as an overview, we use bolsters, and it's a third type of manual hold. It's beyond the scope of this presentation to go more into to describe this much further, than to introduce a concept. We're going to address the problem of progressive intraneural capillary closure. We use a physics principle called Bernoulli's principle to reduce distal volume and resistance while increase proximal capillary velocity. Subholds are necessary to ensure the treatment is completed in a timely fashion. Because it goes much slower if we don't involve bolsters and other holds more proximal to the area that's being treated. Okay, there is a sensory portion. The sensory portion, again, to go into exactly what the sensory is and to explain it in depth, that's beyond the time that would allow for this presentation. However, I'm going to just kind of give you an overview. The sensory view is used to determine the area that appears to be most ischemic. And there's two separate, or actually three separate components to it. The first one involves muscle tone. The thought is that muscle tone is treated in patterns in the cerebellum. And what we feel is going on is that we're seeing muscle tone and sort of pattern changes in both the tone of the fingers and hands as we're coaxing circulation up through a specific nerve. And what we're seeing and what we believe is going on is that we're getting better afferent or spinocerebellar input into the cerebellum, and it's able to modify and give us better muscle tone and modify the cortical spinal tract. And so you can sort of see the impact of nerves performing better as we're getting that circulation into the neural connective tissue. So we look for those changes, and we'll modify the therapy, and we'll position the therapy in what we feel is the best way to accelerate the circulation through the capillary beds. And so we also look at skin color, and we'll also feel for swelling reduction. And so there's many different things that we can use for an in-treatment assessment to make sure that we're doing the right thing, we're treating the right area, as well as to assess how our treatment is progressing. All right, now there is a strategy, an in-treatment strategy for treating someone with neuropathy. And some of this might seem similar to lymphatic drainage in a sense, but there is a necessity to initiating care distally and opening up circulation proximally, and then finishing with distal care. So proximally, I'm talking about more of the trunk area. We call that sort of the neutral area. And so we start off by treating distally. And what we're assuming is that we're going to create, if we just stay with the treatment area, we're going to create some swelling, and it's going to be hard to push circulation through the swelling since the system is used to not bringing circulation all the way out to the skin, say, in someone's foot that has neuropathy. So we initiate care there, then we go and we open up circulation more in the neutral area, and we finish up once we open up the circulation in the neutral area so that it can quote unquote accept the circulation distally, we finish up by opening circulation distally. So I want to really, the whole goal again is to create a new neurovascular pathway, a patent neurovascular pathway between previously ischemic capillary beds and the greater neurovascular circulatory system. All right, so that's just a brief introduction to the therapy. We've gone into a certification process so we can train therapists. We've gone to a way to treat these patients systematically, and we're excited about this. But I would like to kind of shift just a little bit to think about, okay, what about as a physician, what does this mean for me? What does this mean for my neuropathy patients? For instance, you have a clinic, a research clinic out in Loma Linda. So, what does this mean? So if perchance one of your patients did end up in our clinic, and we would look at seeing the patient for a series of INS sessions, at least 12. And for the more severe, it can go up to 24 sessions. And so the goal would be to expand the neurovascular system and promote angiogenesis sufficient to allow for neurodegeneration. So at the same time, we understand there's different types of neuropathy. Some are diabetic, obviously, some are autonomic. We have as well chemotherapy induced. So and then we have as well as there's genetic causes, and so there's also could be nutritional causes. So we would try to, when they're in the clinic, through history, through working with the patient, try to identify if there's any confounding factors that may be that would make it harder for the patient to progress with the therapy. And we again would use the NVI assessment system. We would also use more conventional ways of looking at neural performance. We were developing our own tool, but we'd also use like the Michigan Neuropathy Scale or light touch or sharp dull or vibration, quality of life questionnaires. So all those that we use for an assessment, and then we would look, see how much of the whole patient we can bring into their therapy. We would also teach the patient home exercises so that they can bring what we're doing home, and they can repeat this and allow for even on their off days the promotion of circulation into the nerves using the essential principles that we're using here in the clinic. So what are confounding factors for the therapy? We've talked about some here. Again, you're referring a patient to the neurovascular therapy center. So what would make one patient's experience maybe just a little different here than, say, somebody else? One patient they're completely cured, or they report no paresthesias. The other patient reports some improvement, but they still have some existing paresthesias after 12 sessions each. Same therapy, what's the difference? Well, first of all, you have to look at the extent of the vascular ischemia. How bad is it? 20 years of non-treated neuropathy. The patient has been non-ambulatory. So you can see that would be a patient where our goals would be a little different, and the response might be a little different than, say, an athlete, somebody that has recently had chemotherapy, has otherwise taken good care of themselves, has minor symptoms, and they're coming into our clinic, and they would have maybe we aren't able to necessarily elicit any issues with vibration assessment or sharp dull assessment. In other words, they have full sensation, full strength. They just have paresthesias. Their experience will be different. Their vascular ischemia will also be different as well, necessarily. So we can't expect that everybody's just going to be cured when they come in, obviously. And so we're realistic with and forward with our patients regarding this. We also have to look at the extent of neural degeneration. We have to look at it different than vascular ischemia. And again, this has been, you're looking at, we're doing a vascular treatment, but could be neural degeneration. Neural degeneration takes time. Vascular ischemia is something we're trying to impact right there in the clinic. And even that takes time to heal. So, when the neural degeneration, for regeneration to occur, especially if you're dealing with a motor problem, like, you have motor implant changes, you have, changes in the cerebral cortex. So, with all that, what's the extent of the neural damage that is being brought in? And it should vary from person to person. And so the outcome should vary as well. If there's been prior history of trauma, that may play in. You'd be surprised that it doesn't play in as much as you think it would. There's also genetic factors that could weigh into the patient's ability to heal and not heal. Patient willingness to participate in the program. Sometimes I've had husbands bring their wives in, their wives don't want to be part of the program. Obviously, if a patient really wants a therapy to succeed and they're invested in it, and they believe that it will help, then that's obviously going to go a long ways towards success. On the other hand, if there's skepticism because people are promising the world before and they haven't exactly delivered, and here we are, that could be a challenge. Autoimmune considerations. So obviously, celiacs. I have celiacs. There's also gluten sensitivity may play a part. There is strong evidence that indicates that endothelial dysfunction occurs with gluten sensitivity. And there's other thoughts looking at leaky gut syndrome and large proteins and antibodies and different things. And we've looked strongly at about anything that we can do to put our hands on something that's going to keep the patient in a state of constant inflammation. And so we look at all sorts of different causes for autoimmune considerations. Medication, obviously, if they're still on chemo, they're getting chemo tomorrow, we're seeing them today, or we're seeing them the day after chemo, there's going to be more inflammation that we're going to have to work through. But we're happy to partner with oncology and work with patients that we have several patients that have ongoing chemotherapy. So then we go ahead and do the therapy after they have the chemo, so we can reverse the neurotoxic effects and help the patients so they can tolerate many more sessions of chemotherapy than, say, they would be able to tolerate otherwise. We have one patient, for instance, that has stage 4 pancreatic cancer, and yet we've been able to attenuate the neuropathic effects of all his chemotherapy he's had. And so, we feel like we've been able to help him continue to receive the chemotherapy that he needs. Sometimes patients are extremely are emotional about their symptoms, very in tune with their symptoms, and there's a lot of apprehension, and this can, and sometimes they're not. Sometimes they're engaged, sometimes they're not, and this sort of goes into patient willingness to participate in the program. But anyway, occasionally that we'll run into somebody that is struggling with diathesias and different things. And so anyway, all these can be confounding factors for the therapy that makes everybody's experience unique, and they, as they come into our program. Okay. The challenges with the new therapy. We have some challenges. First of all, showing the total program from a neurovascular perspective and establishing goals. Most of the tools for assessment for someone with neuropathy has to do with either questionnaires or has to do with how well the nerve's performing and the sensory strength, reflexes. How is the nerve performing? How are we going to look at the circulation around the nerve is tricky. The patient, for instance, may be performing, and this is critical because the patient may be responding well to the therapy, yet the nerves haven't regrown, so you wouldn't be able to see on a filament exam or a pinwheel, for instance, or a vibration tuning fork. You may not be able to see outcomes yet because the nerves haven't regenerated yet, or in response to better circulation. And so, you're doing the right thing, but it may not show from immediately on a clinical outcomes perspective. And a lot of times it does, though. So, what do we do? So we're working on, that has to do with neurovascular index, how you can really quantify, from a vascular perspective, that a patient's improving. So that could take you to the next step of looking at neural regeneration as a result of the therapy. Patients have come to us with severe neurologic deficits, and that makes it more complex if they have, for instance, a stroke and they have neural problems, neuropathy, in addition to having a prior CVA. We are working and excited about the outcomes we're receiving with patients that have spinal cord injuries, and the ability to reduce swelling after spinal cord injury, even after a long period of time, and to actually see outcomes that do not plateau. And several of our patients, we're just excited to partner with our East Campus Rehabilitation Center and see patients with severe neurologic deficits improving. Autoimmune confounders are hard to identify, and there's not a lot of research. For instance, with food, sometimes a patient, if they eat certain foods, all of a sudden we get a wide variety of neurologic problems or reported problems. And so how do you identify that? The only thing that the gold standard for food, for some foods, are going to be a food elimination diet, which really is an option, a realistic option when it comes to 3 or 4 weeks of therapy here. So we're navigating that as well, and that's again for a different topic and different presentation. So fitting this therapy into traditional therapeutic rehabilitation setting is also a challenge. If you look at traditional rehabilitation, for instance, you're looking at strengthening, stretching, you're looking at modality work, you're looking at maybe some manual therapy work, but you can see a couple patients at the same time much of the day, but here, because we're doing manual therapy, and it involves coaxing that circulation slowly through the skin, through joints, through through muscles and different things, through motor nerves, it takes an hour. And there's significant changes. The patient, 80-90% of the patients report significant improvement after their first session in terms of being able to feel the floor, being able to have better strength. But again, it's not the traditional rehabilitation setting. And that brings us to the next thing: is Medicare recognition. Medicare looks at a variety of codes as being the gold standard, the best practice for physical therapy. For instance, if you do too many 97110 codes for exercise, you could be audited. If you do too many massage codes, you could be audited. You do too many manual codes, you could be audited. So this would be, for Medicare, it'd be 4 manual codes. So if we brought this straight into Medicare and we charge what we were doing, they would think we're massaging the patients, and it would be difficult since they're not familiar with it. We'd have to be audited. It'd be a difficult step to navigate. So these are some of the challenges with the new therapy. Explaining it, dealing with a heterogeneous disease, and then fitting this in with existing rehabilitation models. Here's a strength, and we've gone over many of these already. So it is systematic and training the existing workforce. Patients can do some of this themselves. And we feel like this is also easily researched with promising evidence already. All right, for patient referrals, this comprises much of our patient population, neuropathy patients, diabetic, chemotherapy idiopathic. We also see chronic pain, post-surgical. We feel like this also has a role in helping patients that have success with traditional care. We feel like you can bring this in for ankle sprains, knee sprains, shoulder problems, and ultimately, it's something. It's a tool that maybe shouldn't necessarily be relegated only to neuropathy patients, but anywhere that there's been some neurovascular compromise. All right, I include a couple case studies. So this particular case study is a young lady that had severe sciatica. She had traditional care. She had medications, gabapentin, baclofen, and so forth. The patient did have decreased sensation and pterygic gait pattern. We did an exam on her. We found her to have a high pain level still, even after all these interventions. And she also had a pain pump. She had a gluteus medius gait pattern, decreased gait velocity. We went ahead and initiated care with her, which included intranerual facilitation, food assessment for neural inflammation, INF home exercise, and 7 INF sessions. At the end, the patient reported minimal to no pain with minimal numbness in her heel at her last session. She received INF therapy. The inclusion of her home exercise program, elimination of gluten from her diet, was also part of her therapy. The patient was discharged and with her goals attained. So what we did is we established that maybe she had a predisposing neurovascular inflammatory issue, and we addressed that. And we gave her home INF, gave her INF, and she was grateful for the therapy. Here's another patient with diabetic neuropathy who had diffuse numbness, tingling, sharp pain in her feet that was constant. This also had a patient that received different care for her neuropathy, which was unsuccessful, and I won't go into that. Patient had significant oedema with distal coloration of her feet. Patient received initial assessment, food assessment, INF therapy, home exercises as well. At the end of 6 sessions, the patient reported a significant reduction in symptoms and she was able to manage her paresthesias with her home exercise. The patient therapy was then discontinued with a 3-month follow-up schedule to assess her progress. Okay, so here's a short summary. We are researching and treating patients using a new therapeutic system at the Loma Linda University Neuropathic Therapy Center. We're looking at a unique model of neurovascular circulation, even considering it an organ. One part of the system is intranerural facilitation, which we discussed. And the INF involves multiple holds to systemically bias blood flow into the ischemic nerves. All right, and anyway, here's more of the summary. Thank you again for coming. Questions or comments? And there's the contact information. Thank you so much for attending this presentation.
Thank you so much, Dr. Bussell, for bringing this to us. A few questions. I noticed that the intranerural facilitation, or INF, is trademarked. Tell me about that a little bit.
Well, we're working with the patent office, and so we're acting on their recommendations. The therapy itself is a manual therapy. The parts of the actual tracking, I mentioned briefly the neurovascular index. and which helps sort of quantify our therapy. That is going to be patented through Loma Linda, and I've been encouraged to trademark the term intraneural facilitation. I think it's important to say, though, that really the therapy was, to some extent, it's a manual therapy. So the manual therapy itself is not really proprietary. We're going to be certifying people to do this. But there are some devices that help us to utilize the therapy, and we'll be patenting those.
Very good. So again, you explained to us that the underlying method is to try to relieve ischemia or to improve microvascular circulation.
Yeah.
You outlined some of the various conditions that you treat. Some of the conditions that you mentioned, like fibromyalgia, for example,
Sure.
Perhaps chemotherapy-induced neuropathies like direct muscle injury. How is it that improving circulation in those situations is going to help with this? And specifically, what types of neuropathic pain have the best results for you?
Well, that's a very good question, and it really is a loaded question, but I'll do my best. And this is actually a similar question when we went about our carpal tunnel study with a neurologist. Why study carpal tunnel when you have the flexor retinaculum that's pushing right on the nerve, for instance? And the thought is that much of neural inflammation may actually be due to C fibers within nerve trunks themselves. And so if you can accelerate circulation inside the nerve trunk, then you'll be able to release substance P or reduce the substance P that's being produced by nerve trunks. And so when we did the nerve trunk, when we did the study involving carpal tunnel with neurology, we got an excellent result, and we're working towards submitting that for peer review shortly, and using the Boston carpal tunnel questionnaire. The point is this: the point is that if you can accelerate circulation, you'll have less vascular stasis within a nerve trunk, and then the C fibers within the nerve trunk will be less apt to release substance P, and then start the pain pathway. So that's the first part. Now, what therapies? Well, it is an intensive therapy. I think that if you can get if a patient is working and getting better using traditional care, then great, because traditional care, of course, also involves strengthening, stretching, or maybe returning a patient back in a functional sense. However, if the patient does not seem to respond to more traditional means and wants something that's more time intensive, one-on-one with a treatment that is, I feel, designed to bring circulation into the nerve, then that would be sort of like a next level. And I think that's where we have our place, is with the patients that don't respond to more traditional means.
Very good. So a couple of questions here, similar
Sure.
similar area of the question.
Okay.
So the techniques that you apply in the office,
Yes, sir.
and some of those anatomic position changes in position and changes in flow and so forth occur.
Sure.
And then you're working with patients then to continue certain types of maneuvers then at home?
Oh, yeah.
And someone mentioned here a question: what do you consider success after how many treatments, at what cost, how durable is the therapy, with or without HEP?
Wow, these are really good questions. So, well, first of all, success is going to be, I think, the easiest, and surprisingly the easiest part of the treatment is reduction in pain. That's usually with our patients that have neuropathy or neuropathic pain. That improves the fastest. And so to some extent, that's success. Now, that's not universal, but there's a high percentage of our patients that have that. The second parameter of success is, okay, what about numbness, tingling, some of the paresthesias, which are a little more harder, that may be more ingrained or more part of their neuropathy. So we want that to improve as well. And so to give a summary to that to that question. Success is going to be when, number one, the patient has shown increased sensation, a significant reduction in their paresthesias, understands what possible comorbidities, what is, if they're autonomic, for instance, what could be bringing on, what they are doing to bring on their neuropathy themselves. And that's taken some time to work through. But the last thing is that the patient now will also be independent with doing the therapy themselves. As I'm sure the physicians are all aware, neuroregeneration takes time, angiogenesis takes time. But if we can give them a good head start, if we can have a significant reduction or elimination of pain, if the paresthesia is significantly reduced, and we can about 70-80% of the time attain those goals in 12 sessions. That's pretty good. And so that's what we tell our patients. That's our goal. And then the patient now has a tool that they can take home. They can do the exercises, maintain the diet, and then we do a 3-month follow-up to see how everything's working. And then we might make some minor modifications if they're plateauing with their home program.
Very good. Another question from the audience. How does one perform INF treatment on neck pain, mid-back pain, headaches? Are those things that you
yes.
treat at all?
So I'll tell you what's really exciting is to work with the physicians here at Loma Linda who are also treating some of these similar disorders to see how we can work together. And I think it's wonderful to have that collaboration with physicians, with patients that have migraines, when patients have neck pain. So I'll give you an example for neck pain, for instance. So the facilitation hold, as described, I can even just show you with my hand, and you just put a joint in a loose pack position. And if you have a relative or a friend that has paresthesias, migraines, or whatever, you can sort of do what I did when I first started. Is if you put a joint in a loose pack position, just hold it. They will have an increase. It won't necessarily be painful paresthesias, but they'll feel something different. And then when you stop the hold, that goes away. So we initiate the facilitation hold to treat neck pain. But then there's a secondary hold. The secondary hold will be what nerves am I targeting? So if I'm targeting, say, the accessory cranial nerve, then I would stretch out the upper trapezius, which it innervates. And so the thought is I've increased the epineurial flow to that nerve, the particular cranial nerve, and then I've stretched out the efferent nerves as they went into the upper trapezius muscle. That pulls apart the perineurium. Now circulation will start to go into the intranerual capillaries. And if there's some inflammation, closed capillaries, problems associated with getting circulation in there, paresthesias, that can be at least a start of their home exercise program. And for therapy, that would be how we would say treat neck pain here. We can do mobilization techniques in addition to the facilitation hold, which would engage sympathetic nerves at the facet joints. We can say, we can do a jaw mode for cranial 5, and understanding that the trigeminal nerve is also associated with migraines to help get circulation into that area. The vagus nerve, there's if you pull in the ear, there's a branch that goes from the vagus nerve to the ear, and that will we found that doesn't help encourage circulation to go and helps out with migraines as well. So there's a whole, and we go over the different algorithms and ways to approach some of these different disorders. The most interesting thing is with Bell's palsy, where we can pull in the tongue and get circulation to the 7th cranial nerve, to the tip of the tongue, in addition to the facilitation hold. And usually after, if it's not too chronic, and even with chronic cases, we're able to see significant improvement in their mouth and in their eye drooping as well. And that's actually most gratifying. We have some excellent case studies and very good responses with Bell's palsy.
Very interesting. Another of our participants here asks, how did you discover INF treatment?
That's a very good question. So, in part, being a physical therapist, I felt like there was a lot of people progressing from different modalities whether acupuncture, and they were doing very unusual things, and people were getting better using, even with mobilization, stretching, manipulation, that was difficult to explain by their models. And when I started evaluating neural models, and then when I came across this one facilitation effect, it all started to click together. And so then there's been a lot of research and studying and thousands of hours working on patients. When I was in South Carolina, I would have the church members come over after church, and if they had some nerve pain, I'd be working and trying different, rationale and thought and different positions to hold them. And as long as they felt better at the end, it was a great experience. So anyway, it's been quite a journey working through it. But it initially started with the thought that I have two special needs boys. What can I do as a parent to help them out and reduce their inflammation? One child with seizures, one child with Asperger's. And so that led to osteopathy, that led to looking at different models. And so it's kind of evolved into this.
Well, Dr. Bussell, thank you so much for your time and for sharing with us your innovation. Very interesting. A lot of responses from our audience here, so you've generated a lot of thought, and you may get some phone calls.
Well, I'll tell you one last thing. We want to support the physicians, and we know that they work so hard, and so that's been a real passion of mine. Is what can we do best to support the physicians with their ministry, and here, the Ministry of Healing, and so we'll just keep plugging away, and hopefully we can provide something that can better support your patients with neuropathic pain. Thank you very much.
Thank you very much.